Very important to know that MRI is now increasingly being used, and it is very important that one does MRI to look for the anatomy of the membranous labyrinth and the cochlear nerves. I'll show you, you will see cases of these. Again, it is extremely important to be aware what technique is being followed. I know you're all from the clinical side, but from wherever you all come, the images which come from different institutes, it is important that what technique they are following, because otherwise can you all hear me? Yes. Otherwise, there can be problems, especially in cases of cochlea. We are trying to look for very fine structures, and if you are not going to do a high resolution scan with very thin slices, you can miss a lot of abnormalities. So it is important that we do this thin, at least 1 millimeter slices. In fact, with the advent of the multi-slice CT, which is nowadays available in most places, especially in Bombay, there are so many multi-slices which have come. The resolution and the slice thickness has gone down to 0.6 to 5 millimeter. So you can get very thin slices, and therefore the resolution improves. And it is extremely important to view these thin slices, and appropriate windowing, again, it's very important. So these are some certain things which you should insist for the radiologist, whoever is, wherever you all get these scans done. Again, for MR, the technique which is used is something called as this fast imaging enabling state, steady state acquisition, or the 3D Fiesta sequence, which is in G machine, and on Siemens it is called as a 3D CIS sequence. Now this sequence shows a very exquisite anatomy of the nerves as well as of the membranous labyrinth. We will see cases of these. So it is very important to do this thin high resolution technique to see the membranous labyrinth and the cochlear nerve. Again, in all patients who come for implant, we do a limited brain MRI, titubated axial sequence, to look for any abnormalities in the brain, such as torch infection or demyelination, because those can be another factor to be taken care of. This is just a line diagram which shows the anatomy. I'm sure you're all aware of. What you need to understand is that on CT, what you're going to see is the bony labyrinth, whereas the MRI shows the membranous labyrinth. So this should be clear to all. I'll just quickly show the anatomy, what we commonly see relevant to the cochlear implant. Since there is limitation of time, I can't go into details of the entire temporal bone anatomy. So these are the actual slices which we obtain. These are thin high resolution slices. These are scaled to 1 millimeter slices. What you can see now, these are slices taken from below above. This is the carotid canal you can see, and this is the jugular canal. As you go up, you will see the basal turn of the cochlea. This is the basal turn of the cochlea, and this is the cochlear promontory. And you will see the middle and the apical turns. This thick bone here is the interscalar septum, and you should always try to distinguish. You can see here there is a thin septum which distinguishes the middle and the apical turns. So you should see these three turns very well, because congenital anomalies would be identified if you don't see these turns and the interscalar septum and these thin bone between the middle and apical turns. This is the stapes, which is seen here, the crura of the stapes and the body of the stapes, which is seen here. And this small structure here is the round window, which you can see in this slice as a small air structure. And as you go higher up, this is again magnified view of the same, the basal turn of the cochlea, the middle and the apical turn. And as you go further higher up, you will see the vestibule, which is seen here, and then you start seeing the semicircular canals. The semicircular canals, in order to see the anatomy, you have to see both in axial and coronal plane. You start tracing these structures. This is a horizontal semicircular canal. You should see it in its entirety. And the superior semicircular canal, you see the two crura, and as you go up, you can see this two crura. As you go up in higher slices, you can see the topmost portion. So you start tracing these lines from below above or above below, and trace each and every structure on both axial and coronal. Some other important structures to be seen on the axial slides is this is the cochlear canal, and this structure is a modulus, because these are again important for the patients who come for implantation. You should be able to identify the internal auditory canal. This is the internal auditory canal, which is where the 7th, 8th nerve complexes would go, and this is the area where the facial nerve goes, you will have the geniculate ganglion, and as you go down, you will see the rest of the facial nerve, which is a tympanic segment going below the horizontal semicircular canal. So this is the seventh nerve, which you can see it here. On coronal, again the same slides. Now on the multi-slice CT, we don't put the patient in prone position, and of course in small children we cannot put them in prone position. So the same data is used for reconstruction to get coronal anatomy, which comes very good because the actual voxel size in a multi-slice CT is isometric, so you get very good reconstruction. So this is again showing the cochlea. You can see the basal turn here. This is the internal auditory canal. You can see this thin canal here, which is the vestibular nerve canal, the nerve which is going towards the vestibule. You can see the horizontal semicircular canal here. So you trace the horizontal, superior, and the posterior semicircular canal as you go more posterior. You can see the turn of the cochlea here very well, so you should be able to identify the entire cochlea and see that it is well loosened so that there is no bony ossification or any abnormality within it. We can get curve reformations. This is just to show a curve reformation which can be obtained on a multi-slice CT, which is showing the curve reconstruction of the entire cochlea, the vestibule, the semicircular canals, and the facial nerve showing in its tympanic segment and the mastoid segment. On MR, again, the important thing to see are the membranous labyrinth and the nerves. So as you go from above downwards, this is the seventh nerve, which is anterior. Eighth nerve is always thicker than the seventh nerve. And then you should start tracing these nerves from below above, where you can see now, important thing is to look at this modulus, which is seen as this hypointense structure here. And this thin line, which you can see here, is a cochlear nerve. I'll show a magnified view here later. Will come later. So this is the cochlear nerve, which you must be able to identify on the MR. Then you can also trace all these structures as we trace on the CT scan. Like for example, this is the semicircular canal, horizontal semicircular canal, and as you go up, you will be able to trace the other structures the same way as you saw on CTs. The cochlear nerves, initially when we started, we used to do reconstruction of this Fiesta sequence. Actually, a Fiesta sequence is a high resolution 3D sequence, so the whole data set you get a 3D volume which you can reconstruct in any plane. But whenever you do reconstruction, there is loss of resolution. So what we started doing is doing a direct sagittal imaging, a separate sequence which is done in this plane perpendicular to the internal auditory canal. So you can get this 4-nerve view within the internal auditory canal. So again, this is extremely important. I think you all should insist that whenever you all get these MRI scans, to get these 4-nerve view, which is a sagittal, oblique sagittal direct plane view of the 4 nerves within the ISC. So you will have the facial nerve, which is seen in the anterior superior portion, the superior and inferior vestibular nerve, and the cochlear nerve. So you should be able to identify the cochlear nerve, and you usually, if in a good scan, you will be able to see the cochlear nerve very well. Then there are certain other structures we realize in a good high resolution scan. You can see this is the interscalar septum, which is nothing but the structure which comes out from the modulus, and there is also the structure called as the osseous spinal lamina, which I'm sure you are all aware of, which also can be identified on a high resolution MR, because this is where the hair cells would be laid, the organocorda will be laid. So you can identify all these structures on the MR. You can get beautiful 3D reconstructions. The same 3D data set can be used to reconstruct, and you can get this image which is almost like showing a normal, actual in vivo anatomy. This is the magnified view which I was talking about. This is the cochlear nerve, and this is the modulus. The modulus should be seen again well as a nice thick conical shaped structure on the MR. So now coming to various abnormalities or pathologies. First, to begin with the anatomical variant. The jugular canal at times can be high riding, which is there are different landmarks used. Mostly when it is above the level of round window, it is considered to be a high riding jugular bulb. In this particular case, this is a dehiscent bone here. So therefore, the jugular bulb is protruding almost inside the external auditory canal and the middle ear. So one should be able to identify this. This is the cochlea, which you can see here. This is a round window. So you can see the jugular bulb is high riding as well as dehiscent. Then there are other abnormalities which can be of the carotid artery, agenesis, aberrant carotid artery which can protrude, and there are various congenital anomalies which I would like to now concentrate upon because those are the most largest group of patients who come for cochlear implants. There are various classifications which are used, and from what we realize from the ENT team here is that this classification which normally ENT people follow is by this person, Senaropoli, it's a very complicated name to pronounce, which was written in this laryngoscope article, whereby he has divided the various malformations into cochlear, vestibular, semicircular canal, ISC, and various cochlear and vestibular duct malformations. So we studied a lot of these patients. We did a retrospective analysis, and we had classified these based on that article into different abnormalities such as Michel's deformity, common cavity, cochlear aplasia, hypoplasia, the incomplete partition type 1, type 2, and we also noticed, because this article was written much earlier, and we found that the cochlear nerve, because MRI was not included, we found that there are some patients who can have isolated cochlear nerve deficiency, so we included that in a separate group, and also some patients can have this isolated cochlea and the attenuated modulus. So we classified this. In fact, we had presented this in last year in ASNR conference in San Diego. And the basic divisions which this article mentions and which we are following here is by the Cenaroglu and Sachi article, where we classify this into different abnormalities. So I'll just show examples of each of these anomalies. Michel's deformity, as you all know, is the absence of the entire cochlea and the vestibular structures. So an example here, what you will see here is there is absolutely no structure of cochlear vestibule seen. It is usually better appreciated on a CT scan, because where you are going to see a normal cochlea, there will be nothing but a small dense bone which will be seen here. Also, correspondingly, you always see in these patients there is no cochlear nerve or very thin 8 nerve will be seen, and the internal auditory canals will be extremely small. You can see here how small the internal auditory canal is. So this is an example of Michel's deformity. Then we do this thin sagittal images as I showed you earlier, and you can see the entire IC is small. The 4 nerves which should be able to identify, you are not seeing or just seeing one single nerve, which should be a 7th nerve, because patient does not have did not have facial palsy. So you are seeing a 7th nerve, and this is most likely a very thin 8th nerve, which you are not seeing the divisions into vestibular and cochlear divisions. Then there is cochlear aplasia. In cochlear aplasia, there is complete absence of the cochlea. You can see a small vestibule. Common cavities where both the cochlea and the vestibule form a single cystic cavity. In cochlear hypoplasia, we will find the structures to be well differentiated, but they will be small in size. So this is an example of a cochlear aplasia. You can see that this structure which is seen here is the deformed vestibule. The cochlea which should be seen anteriorly is not seen. So this is aplastic cochlea. Again, the reconstructed images really help, because you can see that a cochlea which should be seen in this area, as you can see on the opposite side, is not seen. And this is a small dysplastic vestibule and as well as dysplastic semicircular canals. On the opposite side, the same patient had an abnormality where you can see this dilated cystic vestibule as well as the cochlea. The entire modulus which is seen, as I showed you earlier, the normal anatomy, you just can't see the interscalar septum, you can't identify the modulus. So this is how incomplete partition type 1 anomaly would look. So this is an example of incomplete partition type 1. Again, in all these patients, we look for the cochlear nerve. Common cavity, which will be both the cochlea and vestibule will form a single cavity. You can see as in this case. Incomplete partition, I already discussed. Type 1. A type 2 abnormality is nothing but Mondini, classic Mondini deformity, which initially Mondini had described, and there are a lot of confusion as to pseudo Mondini, etc. So now we follow this classification because it makes it much easier. So classic Mondini or incomplete partition type 2 is where the cochlea consists of only 1.5 turn. The middle and the apical turns are fused together, and there has to be always an enlarged vestibular aqueduct. So what we will see here is fusion of the middle and the apical terms. As we had seen in normal anatomy earlier, you should see a thin septum, which you are not seeing in this case, and the vestibule itself is dilated, and you can see a large vestibular aqueduct, which is seen here. Also note that MRI shows the same abnormality very exquisitely. You can see a large vestibular sac. The duct and the sac, both these structures can be identified on the MR, because the sac goes in the CP angle system and would abut against the posterior part of the petrous bone, and you can see this structure here, which is a dilated vestibular sac. Another example where you can see a gross dilatation of the vestibular aqueduct, which you can again see the same finding on the MR. And note that the cochlear nerves here are normal. You can see very nicely the cochlear nerve, but what you will also notice is that the modulus in this is attenuated or thinned out, and usually in all incomplete partition type 2 you will find a thinned out or attenuated modulus. Dilated vestibular aqueduct, at times we have been seeing an isolated dilated vestibular aqueduct, but now there are a lot of articles which now say that usually there is some abnormality of the modulus in these patients, and there are some kind of incomplete partition type 2 abnormality itself. So this patient who has a large, huge, you can see this reconstructed image showing it beautifully, the cochlea, the vestibules, the semicircular canal, and a huge dilated vestibular aqueduct and the sac. Cochlear nerve deficiency, which again has been reported a lot of articles on imaging and radiology, and there are no articles that we could find as to what should be the size of cochlear nerves. In fact, we are doing some research on this to find a database of having a normal cochlear nerve dimension and what are these dimensions in patients who have sensorineural hearing loss. And there was one article which we found where they have described the cochlear nerve size in relation to the facial and the vestibular nerve, and what they found is that usually it is the largest nerve, and in 90% of the cases it will be larger than the vestibular and the vestibular nerves, whereas in 64% cases it will be almost of the same size or slightly larger than the facial nerve. So by and large it should be the largest nerve, or you may find it to be size equal to the facial nerve. So an example of cochlear nerve deficiency, you can see the cochlear canal here, and you just can't see that linear structure which we saw earlier. So therefore this is a deficient cochlear nerve. Again, we do not use the term absence of cochlear nerve because our resolution may not be enough to show some thin fibers. So therefore we call them as cochlear nerve deficiency instead of calling an absent nerve. Sometimes we just don't see, so we report that we are not seeing the nerve and we use the term deficiency. And again, these reformations, this is a reformation which will show that the nerve is not seen here. So that 4-nerve view is very important to depict this, because at times you may not be able to correctly identify it on the axial scans. Then there is this new entity, I mean it's not a new entity but known entity, which is called as the isolated cochlea. In this what happens is that the cochlear canal where the nerve would pass, there is a thick bony bar present. So therefore you will not see the normal cochlear canal, and therefore the cochlea, what the term used is isolated. So therefore it gets isolated. This is just to show a normal cochlear aperture. You can see these two structures as linear hypodensity from where the cochlear nerve would pass, and this is how it should normally be seen. As against this, in this patient there is a thick bony bar which is present, which is an example of isolated cochlea, and by and large the cochlear nerves will be deficient or almost absent in patients who have isolated cochlea. Another example, you can see a thick bony bar. In fact, the modulus itself looked very thick in this patient, and you cannot see the cochlear nerve on the MR. We are trying to do some research work thanks to Dr. Kirtane, Dr. Gauri and Rajesh here. We are trying to do some work on measuring the cochlear canal diameter and the nerve. You can see this cochlear canal diameter, this is how we are measuring it, and see the nerve correspondingly in the same area and taking the dimensions to come to some conclusion. Hopefully we will come up with something. Then coming to attenuated modulus, where the modulus, as we saw, nice big structure which is a conical shaped structure which should be seen. It will be deficient and thinned out, and since this structure supports the organ of Porta, it is important to identify this. A normal modulus which is seen as this conical shaped structure here, and you can see in this particular patient this is attenuated and markedly thinned out. In all patients, as I said earlier, we do an MRI of the brain, and you can see that this deviated axial sequence showing this subcortical hyperintense lesions which this patient had taught infections. So one should always ask for doing a limited MRI brain sequence in all these patients. Now coming to, apart from the congenital anomalies, other abnormalities which we commonly see in those patients who come for implant. These are the various otodystrophies. As you all know, this can be otosclerosis, Page's disease, fibrous dysplasia, or osteogenesis imperfecta. Otosclerosis is basically an abnormality which is of the body labyrinth. It is usually seen around the stapes, the oval window region, which is called as the fenestral type. When it is seen in the entire cochlea, it is called as the cochlear variety, of which the fenestral type is more common. An important thing to know is that pathogenesis of this is in early stage, it produces a spongy newborn formation, and therefore it will be seen as a loosened structure, and later on it gets ossified. So what you will see in an early stage is a loosened area, especially seen around, this is the fenestral type in the region of the stapes, footplate of the stapes or the oval window area. At times, if you give contrast in a very early stage, you might see enhancement. This is a post-contrast MRI which shows enhancement in the same area because it's in an early stage where there is a lot of inflammation. This is an example of a cochlear type of or a combined type, actually it's a combined type of otospongiosis, where you can see a lucency around the turns of the cochlea all throughout. So this should not be mistaken, and it is a very simple diagnosis. I'll just take 2 moments.
No, you may continue.
Same thing seen on the coronal view. Labyrinthitis again, there are different etiologies, of which most common is a viral infection. Again, important thing to know is labyrinthitis in an early stage, there are different phases, of which acute exudative, fibroblastic and finally osteodeposition stage. So depending upon what stage you would image, you will find different abnormality. In an early stage, it is your CT scan which shows labyrinthitis ossificans as bone formation may not be seen in a very early stage. So there MRI helps because as we saw earlier, MRI helps to show the membranous labyrinth, and therefore what you will see on MRI will be lack of the hyperintensity. You can see the cochlear turns which we normally see on the MR. The hyperintensity will be lost, and therefore in a fibroblastic early phase you will just see the loss of lucency, and later on if you do CT scan in the same patient you will find that there is ossification. You can see this, the lucency which is seen on CT scan, the hypodensity will be lost, and you can see bone formation. So this is a very classical example of labyrinthitis ossificans. This is just to show an example of the cochlear implant where you can see the normal position which is seen in the basal turn of the cochlea. And I think I have just to show a video. We can do a lot of stuff on the new multi-slice 3D CT. I don't know how far it helps, but our ENT people are very happy to see these kind of 3D pictures to show the various rotation and movie file. So to conclude, it is extremely important to have these baseline CT as well as MRI combined together to image these patients who come for cochlear implant. And apart from looking for the various abnormalities, one should look for the cochlear nerve and the various malformations as I discussed earlier. Thank you for your kind attention.
Thank you for a wonderful presentation, Dr. Gupta. The next